And thank you, Tom. You've already made some interesting comments and questions in the previous session. So it looks like your background is very, very interesting and pertinent to today. And so thank you for joining us. And your background has been in the medical field, including general practice and indeed the Territorial Army. Dealing with a whole variety of people over the years in situations of conflict and distress. Very interesting that you've chosen to join Strathclyde University's course in mediation and conflict resolution, and you're doing some reflections on that in how reflection takes place, including looking back at good practice or practice from your own medical career, and the issue that was just being raised about videoing our reflections and what we can learn from that. So, Tom, over to you. As you say, you have 20 minutes, and we're very interested to hear your reflections on reflective practice. Thank you.
Okay. My name's Tom Scade, and I've been asked to do this short presentation on the lessons to be learned about reflective practice from medicine. So I'll share my screen. Can everybody see my shared screen? Yes? Yes?
Yes, we can see it. Thanks, Tom.
Very good. Okay. So as Lynn said, I'm a student at the University of Strathclyde. I'm not sure whether I'm the oldest student, but I'm a student and really enjoying the course. Working in the law faculty on a master's degree in mediation and conflict resolution. And that's part of the Faculty of Humanities and Social Sciences. So hence the kind of orange branding. I've been asked to talk on this lessons in reflective practice from the medical field. And as Lynn said, I've got a wide experience in medicine, from internal medicine, general practice. I worked for Emirates Airlines in Dubai as an aviation medical specialist. And I returned to the UK and worked in occupational medicine. And during that whole period, from about the early 80s onwards, I've been involved in reflective practice, partly as a GP trainer, where we tried to teach reflective abilities on the consultation with trainees, but also as part of my own reflective practice and the need for reflective practice in appraisals in medicine. So it's reasonable to say what's the definition, and the definition produced by the Academy of Medical Royal Colleges and the College of Postgraduate Medical Deans was that the process is where an individual thinks about anything relating to their professional practice, but mainly to gain insight, to maintain good practice and to make improvements. Now, Sean is one of the gurus of reflective practice, and he had a very good definition. It's the practice by which professionals become aware of their implicit knowledge and learn from experience. And I think that is a very good, and it's what we really do. And it's reasonable to ask, can you see that band at the top there, which is annoying? Why is it done? Well, medical practice nowadays is a very complex and increasingly complex environment. In the NHS, we work in a very complex interlinked health system, which is underfunded. There's rapidly increasing and changing knowledge, really is witnessed by the increased knowledge of one little virus, the COVID-19 virus, over the last 2 years. And a changing patient base. Some patients come really well armed with knowledge from the internet, and some come very disinformed with knowledge from the internet. It's a dynamic process, especially in the consultation, especially in general practice. And there's always uncertainty present. You're never quite sure of what's happening. So therefore, fallibility is built into the whole process. And self-reflection and reflection with colleagues is essential. And it's essential to improve your ability to be self-aware of your emotions, your biases, and the limits of your knowledge. And identifying bias is difficult. If to try and improve competence, and you've to improve over time. We expect junior doctors who might be in training for about 7 years to become more expert or have more artistry in the process so that they can practice independently as consultants after that. And we also want to improve safety. That's a big issue. So it's reasonable to ask, how do physicians reflect? And physicians, well, reflective thought was described by Dewey in 1910, and then Schoen refined that in The Reflective Practitioner. He described the reflective practitioner. In medicine, a researcher in Brazil called Mamede, who was a doctor, and a Dutch psychologist called Schmidt, they really confirmed the processes. They used Dewey and Schoen's constructs as hypothesis for a questionnaire they produced. They had 3 of their constructs and then 2 of their own. And with that, they really confirmed that to reflect in medicine, you've got to be willing to reflect. And some physicians don't seem to be able to do it or don't want to do it. You've got to have, when you come to reflect, you've got to have a state of doubt or perplexity or uncertainty. This was described by Dewey in 1910. And then there's a hypothesis formed, inductive thinking. You produce a hypothesis about what's happened and what's going to happen, which direction do I go in from here? I'm not sure of what's happening. Then there's a more deductive type of thought, focusing on the implications and also testing these hypotheses. But that might be in a consultation, re-examining the patient, taking the history again, talking to the relatives, talking to other doctors, carrying out investigations, tests, etc. The ability to reflect is helped by a process called metacognition. That's the ability to observe yourself in the consultation and the thought processes you're using in that process with the patient. Now that is an advanced skill and difficult to do, but can be learned. And metacognition was found to be linked to the ability to have inductive thinking, and the willingness to reflect was related to the ability to engage in deductive thought. Schoen had interesting concepts. He postulated that artistry in professions is based on reflection. And he described 2 processes, reflection in action and reflection on action. In reflection in action, he described a process called thinking in action, which he really meant by that the tacit knowledge or experiential knowledge of the person. Experiential knowledge has been called, in some cases, tribal knowledge or tacit knowledge. This is applied by the practitioner, not in a logical way, but automatically. And as well as this tacit knowledge, the person brings in to the consultation all his life experience, all his theories, all his technical knowledge, and his ethical background, both his personal one and professional one. So all of these things are used to work automatically. And you're really then using heuristics or patterns, or what some people call them scripts, to identify things that are happening. Now, I'll give you a simple example of this, which really annoys my wife. I can be driving down the street and I'll look out the car, have a 3-second glance of a person we pass and say, I think he's got ankylosing spondylitis. There, I am not logically thinking through that process. I know that. That is part of my thinking in action, because I've seen that in the experience before. I've seen that case. And I'm looking at lots of cues, but I'm not thinking about them. To reflect in action, which is a difficult process, you've got to be aware of a moment of surprise, or in medicine, it might even be worse, a feeling of anxiety, or we would call perhaps that cognitive dissonance. And that's where a person realizes he is seeing something new and perhaps has reached the boundary of this knowing in action or tacit knowledge. And then he creates a hypothesis of thinking, what was I thinking there? But what am I going to think about now? Because something's different. And then the same processes described in the previous slide would be going through examination, etc. Then there's a logical thinking process then, and it's a sort of experimental process in action. Now, all this is happening very quickly in the moment. And as I said, this is the kind of move from the fast system one thinking of Kahneman using heuristics to a slower form of system two thinking, but it's in the moment. Reflection on action is reflection after the event in a more measured way, perhaps identifying the reflection in action that happened, but perhaps looking back at a video of a consultation and saying, teasing out the crucial moments when you didn't say something you might have said, when the patient said something, or when you said something, and where you might have gone wrong or where you did well. And that's a learning experience, so you can away and learn of the deficiencies. Mindfulness and being in the moment is believed to be a skill that helps the identification of these moments of surprise, because you are aware of what's happening around you much more than the normal person. The process of metacognition allows you to think, possibly at that moment, what was I thinking there? How did I get to that stage with this person? So looking back at your thinking processes. This all expands your knowledge in action and links theory to practice and identifies areas of learning and heightens expertise. All that theoretical stuff, this is tacit knowledge in action. This is knowing in action. How do you ride a bike? You can't really explain how you ride a bike. You learn as a child on a kiddie bike. How do you recognize faces? You could not write down how you recognize a face, but it's knowledge there, implicit knowledge. Well, it's not quite implicit knowledge, it's tacit knowledge. Guidelines on reflective practice in the UK have really been developed with this knowledge in mind. It is accepted that there is a variation in practitioners' use of and ability to carry out reflective practice, but it's accepted that reflective practice is valuable in increasing expertise in artistry in practice-based professions and can be taught. So therefore, the Academy of Medical Royal Colleges, the UK Conference of Postgraduate Medical Deans, the General Medical Council, and the Medical Schools Council have produced agreed common guidance on the use of reflective practice. And they see this as the cornerstone of both formative development, but continuing appraisal from medical school through doctors in training to establish practice. They also feel, and this is important, that reflective practice is important in maintaining well-being, both in individuals and in teams. They have drawn in 8 other health regulators, which can be seen if you look at the slides later here, including the Nursing and Medical Council and Dentistry Council, to buy into the concept of reflective practice in their training and appraisal. The guidelines, briefly, I'll show you them. They're on the General Medical Council website. This is an open access website, so you can go into it and poke around. Anybody can look at these things. And it's just really to show the public what doctors are attempting to do. There's a document called the Reflective Practitioner. There is a kind of toolbox you can look at. That contains templates for use in starting to learn about reflective practice. It gives examples of good reflections, bad reflections. It gives videos of reflective practice. Shift that. It gives videos of tutors or supervisors reflecting with doctors, which are good ones and bad ones. So it's a very comprehensive guide to doing this. The main points, and these are heavily summarised, is that the reflection is personal and there's no one way to reflect. Having time to reflect is crucial, and that's important both for your well-being and for your development. Healthcare teams should have the opportunity to reflect and discuss openly and honestly what's happening when things go wrong. And a reflective note, and repeat this over and over again, should not capture the full details of an experience so that that case cannot be identified. It should capture the learning deficiencies and the potential outcomes and what you've done to further your continuing professional development. And this is because reflective notes can currently be required by a court as evidence against that doctor in court. Details, reflections shouldn't be a substitute for reporting critical incidents. And there are various safety reporting systems within the NHS for that. It doesn't capture all the events though. And it is the responsibility of tutors, supervisors, appraisers, and employers to provide time and space for individual and group reflection. The uses are widespread. Medical students, they are taught reflective practice as a formative practice, but then they create a reflective journal throughout their undergraduate training, reflecting on events they come across, perhaps their first contact with death, problems with colleagues, problems of communication. And then that can be used in the summative assessment. Doctors in training at annual review of progress, and that can cover about 7 years, have to show evidence of reflective practice in their journal. Therefore, it's a formative, but also a summative process. Qualified doctors in the annual appraisal process, and then the 5-yearly review of these annual appraisal processes, have to show evidence of reflective reviews of cases, events, complaints, communication difficulties, and good events. And these are discussed with their appraiser annually. Interestingly, the appraiser is changed every 2 years because they want this to remain, although a reflective event, a critically reflective event. Therefore, this is a formative and summative process. The methods they allow most methods to be used. You just have to reflect. And this is an example of the toolbox. You can see there's various different types of templates, which you might want to go into the GMC website or use as hyperlink to connect to. They show evidence of good practice and near-miss reflections, etc., and it includes videos of bad practice. Group methods of reflective practice are emphasised. They feel this is a very good way of learning, but also supporting groups within the NHS. There's various methods. One is the Schwartz round. The Schwartz round was a method imported from the United States in about 2009 into the NHS. This is where groups of practitioners will come together, perhaps different ward groups. And that's not just the clinicians, that might be the porters, the cleaners, physiotherapists, occupational therapists, and ward clerkesses, everybody involved who might be impacted by patient care, and very often by the emotional impact of patient care and the communication and relational activities of the job with all of these people. Several members of the group might present their reflections on a similar event. And then these reflections by these people are looked at by the audience, and it can be quite a large audience. And the large audience might reflect on these reflections, but then they might add their own reflections of their involvement in similar events.
Tom, just to let you know that we're coming up to 12:30. I know we started a couple of minutes late, but just to let you know, so we
yes, I'll finish in
as much as time as we can.
I'll tell you something about, well, there's ballot groups are used in general practice in the same way. Small groups are used in GP training, which I've discussed previously. And patient participation groups are used in general practice, and that's patients. Now, safe space is essential. Health professionals don't feel they have a safe place because the reflective journals can be used. This was worsened by a case called the Bawal Garba case. It was heightened by significant concerns about doctors. This was a junior doctor accused of negligent manslaughter, and she was in fact given a 2-year suspended sentence for this, along with a nurse involved. Other doctors at that time thought her reflective journal was being used as evidence in court, and it wasn't. But this inhibited doctors in training significantly at that time. 81% of doctors changed their reflective practice, minimising it really at this point. And this prompted a government review and a GMC review. And this has produced the guidelines I've talked about today. Now, an interesting thing happened as I discussed this. I'll skip this slide here, okay, as I'm running. Next. I wanted to show this very good video of reflection in action. And I wanted to show it, but as I watched it for the first time, I had a bit of anxiety. And the anxiety was around whether too much information, which might identify the patient, could be seen. I carried on though, because I wanted to show it. But yesterday I was reflecting again on it. And I talked to my wife about it. She's a nurse. I talked to my daughter, who's a nurse and a counsellor. And I talked to myself. So I reflected on it and decided not to show it. I wrote then to the GMC, Ethics and Standards Committee, and said, I'm a bit concerned about this video that's on your website. So that was a reflective practice in action, thinking in action and acting on it. Medicine and mediation have very significant similarities. We both deal with human beings in a distressed state. Communication with the patient or parties is key and can go wrong. We both have a background, a body of theoretical and technical knowledge. It's difficult to know what to do next. There are ethical issues, there are emotional issues, and the nearest branch is general practice, where we both deal with uncertainty and a dynamic situation. So, reflective practice is very transferable to mediation. Right, that's me finished. I'm sorry I ran over there. And I skipped a couple of slides. They're not too important. They were really about the need for a safe space. Safe space is essential because it's a safety issue. The error rate in medicine is high. It remains high. One of the reasons is lack of a safe space. And this issue of reflective journals being used as evidence in court is against safety, and the BMA and the GMC asked for it to be removed, but the Crown Prosecution Service still want to retain the ability to call these in court. Thank you. Thank you very much.
Lynn, I think this is where you want me to take over from you while you go and enjoy your festivities.
Thank you very much.
Tom, have a good birthday with your husband, and we look forward to seeing you again soon. Tom, thank you very much for a very interesting and informative presentation. You did stick to your 20 minutes because you started a few minutes late. Unfortunately, we couldn't see all of your slides, but I think
there's only two missed, and you will see the slides eventually. And it's about safe space, and that's crucial. Yeah.
Excellent.